I'm Andrew Holden from Auckland, New Zealand, and I was lucky enough many years ago to be the first to use Shockwave, and right from the start, I could tell this was a very important and disruptive technology. To discuss these important results, I'm really joined by a prestigious panel who has a lot of experience in Shockwave IVL. We're going to hear from Dr. Sahil Parikh, Dr. Mariam Brodman, Dr. Saram Mangal Murthy, and finally, Dr. George Adams. A little bit about intravascular lithotripsy. Obviously, it's a simple over-the-wire catheter-based therapy, so something we're very familiar with integrated IVL sources within the device emitters that produce high energy emissions that microfragment calcium and allow the vessel to expand at very normal pressures. As I mentioned, as I was lucky enough to be the first to use this device in the periphery, but since then, there's been a huge amount of experience in a broad range of applications for Shockwave IVL. We've seen experience not only in the typical concentric calcium, but also in eccentric calcium. It was initially used in lower limb arteries, particularly the femoropopliteal segment, and we've seen it used as a standalone device in that location, but also in a myriad of other peripheral arterial locations, as well as the coronary applications and many other applications, such as facilitating EVAR in the management of aortoiliac occlusive disease. We've seen this technology used not only standalone, but as a vessel prep technology, as we'll see in this randomized controlled trial, and to enable endovascular access, as I mentioned. We've recently seen the early results of the Disrupt CAD3 randomized controlled trial being presented at TCT, and you've just heard the results of the Disrupt PAD3 trial as well. So a very important time for both of these trials and for Shockwave in particular.
Andrew, thank you so much. It's a privilege to be here to present these exciting data. Just to recapitulate for those who haven't seen Dr. Gray's presentation. So for those that aren't aware, the PAD3 study was a prospective, multi-center, single-blind, randomized trial in several countries across the globe, as represented here, with the objective to assess the safety and effectiveness of IVL plus DCB versus PTA plus DCB to treat moderately and severely calcified fempop arteries. The statistical analysis was designed as a superiority analysis performed for primary and a powered secondary endpoint. And what was seen in the consort diagram here is that there were 306 patients at 45 global sites that randomized 1-to-1 to having the treatment with either IVL or plain old balloon angioplasty prior to impact DCB, plus or minus adjunctive stenting, with an acute result adjudication and a 30-day follow-up, followed by subsequent longer-term follow-up at 6 months, 1 year, 2 years, and thereafter. Study endpoints, again, this was an acute experiment in the sense that it was looking for acute procedural success, looking for residual stenosis of less than or equal to 30% without flow limiting dissection, greater than grade D or higher, prior to DCB or stent implantation, as adjudicated by an angiographic core lab. In other words, patients had pre-procedural lesion preparation either with IVL or PTA, and then subsequently they had DCB plus or minus stenting before final assessment. And at each step, there was assessment for residual stenosis and other parameters. Secondary endpoints of note are major adverse events, clinically driven TLR, ABI, Rutherford classification, and walking impairment questionnaires. And the powered secondary endpoint at 12 months is primary patency, and those data will read out sometime next year. Baseline characteristics were well matched in both groups. In addition, reference vessel diameters were between 5 and 6 millimeters, as noted here, with MLDs of 0.8 in both groups, and a percent diameter stenosis in the order of 85%. Chronic total occlusions represented approximately a quarter to a third of patients, and lesion lengths were more commonly greater than what we've seen in the typical IDE trials for drug-coated balloons, over 100 millimeters or so. There were approximately 10% of patients that had lesions greater than 15 centimeters. and the calcification was predominantly severe using the Park definition and predominantly concentric. Procedural characteristics were well matched in terms of time. There was slightly greater fluoroscopy time for the patients who underwent IVL. Embolic protection was used, trending towards less when IVL was utilized, and the need for post-dilatation was substantially less with IVL. Stent placement was likewise substantially less when IVL was utilized, and the number of treatment balloons was approximately the same. Max inflation pressures were substantially less with IVL, and this was quite dramatically demonstrated in the graph on the right. Post-treatment diameter stenoses were significantly lower by a few percentage points in the IVL group, as noted here. And as you can see that there was a greater percentage of ultimate reduction of percent diameter stenosis to less than 30%. Post-treatment angiographic complications, specifically freedom from dissection, was significantly less in the IVL group. Specifically, type C dissections and type D dissections were reduced by using preparation with IVL. The primary endpoint at the initial time point was a residual stenosis of less than 30% without flow-limiting dissection. And as you can see here, from the site-reported analysis, 90% of sites reported that they had treatment success with a stenosis less than 30%. Even when adjudicated by the angiographic core lab, the percent of success was significantly greater in the IVL group compared to the PTA group. The absolute risk reduction was approximately 15%, suggesting that the number needed to treat to have one improved outcome here is approximately 6. In addition, core lab adjudicated reductions in percent diameter stenoses were also similarly reduced in the companion PAD3 observational registry. You'll hear more about that in our subsequent discussions today, but you can see that both in the clinical randomized trial as well as in the observational registry, which included more complex patients with greater vascular bed involvement, there was very similar reduction in complications. There was a single perforation that occurred after DCB inflation and not the IVL itself. So in summary, the Disrupt PAD3 randomized controlled trial provides the largest level 1 evidence for the treatment of heavily calcified femoral popliteal arteries, a cohort that's often excluded from other trials. IVL was superior to PTA in acute procedural success and demonstrated atraumatic treatment with reductions in percent diameter stenosis prior to DCB or stent placement, lower max inflation pressures, reduction in the frequency and severity of dissection, and lower post-dilatation and stent implantation rates. The trial outcomes are similar to the PAD3 registry in multiple vascular beds, highlighting the consistency of the IVL treatment in complex anatomy. And the powered secondary endpoint of primary patency at 12 months will be analyzed following appropriate follow-up for all enrolled patients, and we anxiously await those data in the coming year.
I'd ask you first, Sahil, is there anything that stands out regarding the patients that were recruited to the trial overall?
Well, I think, Andrew, the most important thing is that these are patients that we would not have enrolled in any of the other DCB pivotal trials. In fact, these were the patients we expressly avoided in those trials. And I think that's the most important point. We're treating longer lesions on average with severe calcification, which is frankly representative of a day in the life of any of us who's a practicing interventionalist. And so I think that was extremely representative. More importantly, I would also say, just as an anecdote, we participated earlier this year in a meta-analysis that compiled some of the PAD3 observational data with the other previous registries from the different vascular beds. And what was really astonishing was the remarkable consistency of the result. The percent diameter stenosis reduction was almost identical across vascular beds ranging from the iliacs all the way to the tibials and everywhere in between with severe calcification. And in fact, this is the first device that I've seen that actually does a better job of treating concentric calcium than it does eccentric calcium. Both it treats quite well, but frankly, there was actually a slightly better numerical response in concentric calcium. So I'm not aware of any other device that does a better job the more calcium there is. So I think the data are exciting, and certainly I think will herald a different era in the treatment of severely calcified vessels.
Yeah, congratulations on that meta-analysis. It's very important information and recently published. Another question I have for you, Sahil, is this issue of discrepancy between core lab and site-reported outcomes in the acute efficacy endpoint. I'd have to say, when I look at the site-reported outcomes, they very much correlate with my own acute procedural success results and assessment. And we always see this discrepancy between site and core lab adjudicated results. Have you got any comments about the discrepancy you just explained to us when you reported the results?
Sure. I mean, all of us that work in the clinical trial space recognize that core lab adjudication always is more humbling than our own estimate of our success. I think what's critically important, however, is that the delta between the two groups is preserved. Even with the scrutinizing eye of the core laboratory, there's a substantial delta between the two groups. And again, this is a lesion preparation strategy trial. You see that there's substantially better lesion preparation, irrespective of which methodology is used, whether it's site-reported or core laboratory. And I think that's the take-home message. We would predict that better lesion prep would portend better long-term outcomes, and obviously we await those data very eagerly.
Marion, I want to switch focus a little bit to really think of IVL in terms of vessel preparation. I'd like to understand, for example, the importance in your mind of IVL in these calcified arteries for vessel preparation and how it might compare to standard PTA initially, and then perhaps compare it to some of the other technologies that we have available.
Yes, thank you, Andrew. Sahil had already mentioned the value of IVL for vessel prep and summarized it in a good sentence. With regard to the other vessel prep systems, this is the one who doesn't show any kind of, how to say, difficulties, any kind of problems like, dissection, distal embolization or whatever. And this is a slide comparing IVL in a 100%, I would not say in a 99%, I would say in a 100% severely moderate to severely calcified vessel patient population. And when you look at the comparators out there, atherectomy systems, for example, where we also have data and how they perform with regard to acute gain or with regard to maybe patency outcome, there might not be that big difference. But the biggest difference is that there is no difficulties with regard to complications. When you look at distal embolization, I really remember you did the first cases, I did the second cases. I didn't have embolic protection devices available at the time at my institution, and you reassured me that in the embolic protection devices you have used, there was no debris. So there was the fear in the early cases that we might have debris going down to the foot and causing any kind of complications. This is not the case with this kind of vessel prep system. And also there's a very low rate of dissections, no perforations, no abrupt closure or thrombus or slow flow. So I think this is the outstanding issue of IVL. You can really safely treat calcified vessels we didn't treat before in an adequate way, and you can treat this safe.
Yes, I must admit, Marion, I think you and I both surprised when we saw some of the complexity of lesions that were entered, and as I mentioned, a lot of them entered by you, and without the need for embolic protection. It's always been a surprise to me, but it's something that we've now gained a lot of experience with. Do you think, for example, obviously in the trial, we saw a statistically significant reduction in the need for stenting. And based on your experience with conventional treatment with these calcified lesions, have you been in your own practice in the trial and outside it continued to be impressed with the relatively low incidence of the use of stents in these complex lesions?
Yes, this was also a big surprise because you don't need the stent to achieve a good lumen. And you see here what kind of acute gain we can achieve. And this is really in these long complex lesions. It was really phenomenal with regard what we were able to achieve in an acute result just with this balloon-based IVL procedure. And this is something which was really very surprising. And I think, especially in these highly calcified lesions, you know, doing the procedure, achieving acute gain, and then in this case, like in the DISREPAIR-3 trial, apply drug and not use a stent or need to use a stent. I think this is also a very, very, very good achievement we can achieve with this kind of treatment.
Well, thanks very much. We might switch to now Dr. Sarang Mangalmurthy. Sarang, you were, as I mentioned, the largest recruiter in the US to the randomized controlled trial. And perhaps I just might make an initial question of what you think about are the overall advantages of IVL in the femoropopliteal segment compared to standard PTA based on your experience in the trial and in clinical practice.
Yes, thank you very much, Andrew. So I think for femoropopliteal, you have a much longer area that you have to deal with when it comes to calcified vessels. I think it's pretty clear that heavily calcified vessels need plaque modification. It eliminates recoil, it reduces dissections, and that's the benefit that you get when you perform IVL. And that's also the reason why you find a reduced need for stent placement, you know, in terms of the outcomes that we see from the study. Here's a good example of a patient that I actually enrolled in the study, who has a very calcified, you know, relatively localized, but nevertheless very calcified segment in the mid SFA. You know, with the advent of DCB, the strategy that I like to use in these patients is to try to get the best balloon angioplasty result that I can prior to drug delivery through a drug-coated balloon. And so IVL is nice because it allows you to modify that plaque, particularly that medial calcium. And that's one area where I think our current technology, atherectomy, specialty balloons, really don't address the way IVL is able to address that. So here we use just the technology alone, no other adjunct technology to modify the calcium, and you see the result that you get afterwards. So, you know, a very nice result for a very calcified stenosis that would ordinarily, I think, result in higher rates of dissections and the need for stent placement.
Yeah, certainly that was a beautiful case. And I guess you mentioned last of all, Sarang, stent placement. And when I think of these calcified lesions, and I asked Marianne a similar question, you know, I start thinking prior to the advent of IVL of atherectomy or biomimetic high radial resistive stents like Supera. In terms for these calcified lesions, in terms of the avoidance of, you know, the need for very rigorous pre-dilatation and so on for Supera, what do you think are the real advantages of perhaps being able to avoid this complex stent deployment?
Sure. Well, certainly, I mean, there are some areas, especially distal SFA popliteal, where we avoid stenting, you know, for the vast majority of cases, even though you do have interwoven stents that you can use in those areas. The strategy is largely to modify the plaque and perform balloon angioplasty, and then follow that with a drug-coated balloon elution so that you can maintain, you know, much higher rates of patency. One thing I would say, Andrew, is that, you know, stent placement itself is not a benign process, not just for restenosis, but heavily calcified vessels. Oftentimes, you can get suboptimal stent placement. So if you haven't done enough to modify the plaque, you can get stents that are not fully expanded, stents that will have a higher likelihood of fracture. And so even if you are somebody who is committing to a stent platform for a particular stenosis in the femoral popliteal, IVL is still going to provide you with an optimal stent result in order to achieve full expansion and naturally, you know, as we'll hopefully see, better long-term outcomes for these patients.
Our final panelist, Dr. George Adams, and as I mentioned, George has gained a lot of experience with IVL and over 100 cases in the observational registry. Now, the observational registry is designed to include IVL in all locations, and George has really been an opinion leader and thought leader on the use of IVL outside of the very studied femoropopliteal segment. So my first question, George, really is, what do you think the results of this trial really, how do you think these translate to your experience outside of the femoropopliteal segment for IVL?
Andrew, I think that's a great question. I think the results of the SFA POP trial are very similar, very similar to the results we're seeing outside of that vascular bed. And you put up a nice representation of a tibial intervention I did, and we're seeing similar results. One of the things too, Andrew, just to go back, you had mentioned about stent placement in the SFA and POP, and we're seeing that we aren't having to place stents as well below the knee. And one of the main reasons, I believe, it may be attributed to recoil. The calcium that is affected, this modification that Marianne had brought up, this pliability that we can see, and sometimes we can see it, especially with intravascular ultrasound. After you give the therapy, it's like a concrete tube, but once you use the intravascular lithotripsy, you modify that plaque so that you actually get an undulation type movement. And I believe that allows us, if you need to place a stent, that you can expand the vessel. But if you get a good lumen, you may not have to place a stent, because not only have you affected the intimal calcium, you have affected the medial calcium. And we've also seen that below the knee.
Yeah, that comment on medial calcium is really important. And we know that there's a high prevalence of medial calcification in below the knee arteries. And I guess, George, the standard atherectomy technologies we have, they're well designed for intimal calcification, but perhaps not as effective in medial calcification. What's your thought on that?
Yeah, I think you may be right, Andrew. We really haven't looked at it. And this idea of recoil, until Bowman and Baumgartner had, published that tibial paper showing that recoil after 15 minutes was a significant issue, it really wasn't on the top priority list of the way we were thinking. Now I think when we discuss prepping the vessel, recoil has to be considered in that algorithm. So yes, I think that some atherectomy devices may not be as efficacious as the Shockwave IVL therapy.
And George, finally, we saw Sahil's presentation, a very low incidence of dissection and bailout stenting in the femoropopliteal segment. In your extensive experience in other locations, particularly below the knee, but elsewhere, are you seeing the same thing, that there is a low incidence of dissection?
Yeah, Andrew, and this is case in point. This is a case of an individual who had a wound in their posterior circulation. I was able to use IVL in the TP trunk, posterior tibial, and the perineal. And as you can see to your far right, no obvious dissections. And this was probably, as you can see, we started with the posterior tibial and the TP trunk. This is probably 5 minutes or so afterward. There's no obvious recoil. So, yeah. So I think the answers in the actual case here, that we are seeing very similar results as we did above the knee.
We've been really excited to see the largest ever randomized controlled trial evaluating severely calcified lesions in the femoropopliteal segment, and we've seen primary effectiveness superiority over standard PTA. We saw that IVL was associated with a reduction, as mentioned, in dissections and provisional stenting compared to PTA. And this concept of vessel preparation in a drug-eluting and anti-restenotic age is really important, where we could prepare arteries better at lower pressure, which I think is very important, without the need for stents and for post-dilatation. So thanks again to my fantastic faculty, and I hope you enjoyed this presentation.